بسم الله الرحمن الرحيم. gall bladder by Assistant Prof. Dr. Salah الجنابي, General Surgeon and Laparoscopic Surgeon, Babylon Medical College.
Ultrasound. Ultrasound is the most common test used for diagnosis of the biliary colic and acute cholecystitis. It is 90 to 95% sensitivity for cholecystitis and 78 to 80% specific. For a simple cholelithiasis, it is 98% sensitive and specific. Findings include gallstones or sludge and one or more of the following conditions: gall bladder wall thickness more than 2 to 4 mm, false positive wall thickening found in hypoalbuminemia, ascites, congestive heart failure, and carcinoma, gall bladder distension diameters more than 4 cm و longer than 10 cm, pericholecystic fluid from perforation or exudate. Some sonographies recommended the diagnosis of cholecystitis if both sonographic Murphy signs and gallstones without evidence of other pathology are present. Additional finding in the presence or absence of the gallstones, dilated common bile duct or dilated intrahepatic ducts of the biliary tree indicate common bile duct stones. In the absence of the stones, solitary stone may be lodged in the common bile duct. Location difficult to visualize sonographic. Advantage of sonography include the following: images other structures, aorta, pancreas, liver, identifies complication, perforation, empyema, abscess, rapidly performed at the bedside, no radiation, important in pregnancy. Disadvantage of sonography include the following: operator dependent and the patient dependent, inability to image the cystic duct, decreased sensitivity for the common bile duct stones. Biliary scintigraphy, HIDI, di-isopropyl immunodiacetic acid, nuclear medicine studies. Sonography or nuclear medicine testing is the test of choice for cholecystitis. HIDI scan have sensitivity 94%, specificity 65 to 85% for acute cholecystitis. They are sensitive 65% and specific 60% for chronic cholecystitis. Oral cholecystography is not practical. Normal scan are characterized by the normal visualizations of the gallbladder in 30 minutes. With cystic duct obstructions, cholecystitis, the HIDI scan show non-visualizations, i.e. considered positive, of the gallbladder at 60 minutes, and uptake in the intestine as the bile is excreted directly into the duodenum. Obstructions of the common bile duct causes non-visualization of the small intestine. The REM sign is increased tracer adjacent to the gallbladder at 60 minutes and suggests gangrenous cholecystitis. Advantage of the isotope scan include the following. Assessment of function, normal appearing gallbladder by ultrasound, obstructed cystic duct. Other tests: endoscopic retrograde cholangiopancreatography (ERCP). ERCP provide both endoscopic and radiographic visualization of the biliary tract. It can be diagnostic and therapeutic by the direct removal of the common bile duct stones. Another test هو magnetic resonance cholangiopancreatography (MRCP). Treatment: conservative treatment followed by cholecystectomy. Symptoms of acute cholecystitis subside with conservative treatment in 90% of cases. 4 principles: nasogastric suction and IV fluid, analgesia, antibiotics, broad spectrum effect against gram-negative erupts, subsequent management if inflamed subside, oral fluid, وفat-free diets. Cholecystectomy on the next available list or after 4 to 6 weeks. Conservative treatment is not advised if there is uncertain diagnosis, possibility of high retrocecal appendix, perforated duodenal. Treatment: routinely early operations. Indication: within 24 hours of the onset of the attack. Experienced surgeon. Excellent operating facilities. Cholecystectomy can be done either by open or laparoscopic approach. Acalculous cholecystitis. Some patients have non-specific inflammations of gallbladder, whereas others have one of the cholecystosis. Diagnosis either by oral cholecystography. Acute acalculous cholecystitis is seen more frequently in: first, critical illness; second, major surgery or severe trauma burn; third, sepsis; long-term total parenteral nutrition; prolonged fasting. The cholecystosis, not uncommon conditions affecting the gallbladder where there is chronic inflammations, changes with hyperplasia of all tissue elements.
Cholesterosis, strawberry gallbladder, submucous aggregations of cholesterol crystals and cholesterol esters, yellow seeds in the red mucosa. Cholesterol polyposis of the gallbladder. These are either cholesterol polyposis or adenomatous changes. Cholecystitis glandularis proliferans, polyp, adenomyomatosis, and intramural diverticulosis. Multiple polyps, fleshy and granulomatous. All layers of gallbladder may be thickened. Sometimes incomplete septums form. Intraparietal mix. Diverticulosis of the gallbladder usually manifested as black pigment stones impacted in the outpouching of the lacuna of Loschke. Typhoid gallbladder, Salmonella typhi, or occasionally Salmonella paratyphium, can infect the gallbladder, leading to acute cholecystitis and more commonly chronic cholecystitis. Patient being typhoid carrier excreting the bacteria and the bile. Gallstones may be present. CA gallbladder, rare, common in certain areas as India, where it reaches 9% of biliary tract disease, found in less than 1% of gallbladder operations. In over 90% of cases, gallstones are present. Presentations: age 70 years old, sex female, more than male 5 to 1, pathology serous, but may be squamous cell or mixed squamous adeno. A clinical presentation: either extensive masses in the liver during investigation. Thank you very much.